being recorded, and we will have it available on our YouTube channel. And that information will be provided on our Facebook page and on our website. I'd like to welcome Dr. Helene Alexanderson, and I will let her give you a bit of her background, as she knows a lot more about it than I do. So welcome, and we're so happy to have you join us.
Good afternoon, everyone. I'm happy to be able to speak to you from Sweden. It's 8 p.m. here. I'm a physical therapist, and I've been working in rheumatology since 1993. And as you see in this picture, this is the research group research group and clinical team working with myositis at the Karolinska. So Professor Ingrid Lundberg, she had patients who did not obey her instructions to rest when they were diagnosed with myositis. So she had a young man who exercised anyway, and he came into her office and he was very strong and did push-ups on her office floor. So that made her think that maybe exercise could be helpful in myositis, despite what the textbooks said. So she contacted me quite early, already in 1995, and I started to see the first myositis patients that year. And quite soon, I was able to develop a home exercise program that we tested quite extensively to look that it was safe, and we could also see effects of the exercise. And I will show you that home exercise program later on in this session. But in this research group, we have physicians and physical therapists, occupational therapists, nurse, and basic scientists. And so we kind of work in a parallel line. One part of the research pertains to understand mechanisms of why you get myositis. And the other line goes into how do we care, how do we optimize the care for patients with myositis. And there is where my research comes in to understand, to improve treatment, to understand the effects of exercise. You all know that it was thought that exercise was harmful in the 90s, perhaps, and that knowledge or that notion came from sports research. So they took muscle biopsies on marathon runners, for example. So they took a biopsy right after the race, and then maybe 8 hours later, and then maybe next day, and the next day, and the following weeks. So they did like 7 or 8 muscle biopsies very close to each other on the same leg. So they saw a lot of inflammation in these muscle biopsies, and they thought that it was due to the exercise. So that's how the notion came on, that, well, if you already have muscle inflammation and you already have increased CK levels, you should not exercise. However, we had a muscle physiologist in our group some years ago who had a young man do extensive eccentric exercise, so they could hardly walk the next day. Half of the men did the exercise, but everyone had muscle biopsy done. And what they saw, that everyone had the same type of inflammatory infiltrates. So it didn't have to do with the exercise, more with the multiple muscle biopsies that were taken. But first, during my talk, I want to share with you that we have about 30 studies today evaluating different exercise programs in both adult and juvenile myositis. And the most part of these studies and the most randomized controlled trials are in adult polymyositis and dermatomyositis. But there are some smaller studies also in inclusion polymyositis. One exciting study maintaining blood flow restricted training in IBM. So I will try to go over a little bit of what we know about why the muscles get weak, and also talk to you a little bit about these different kind of exercise programs and what effects we have seen after exercise, both in the muscle tissue, but also regarding disability and quality of life. Maybe you heard of sarcopenia. It's a normal loss of muscle mass that we have with age, starting perhaps in the 40s, so, and then increasing over the years. So when you have turned 65 or 70, your normal loss of muscle mass will increase, and that could be due to different factors. So one could be as you get older, you might have a more sedentary lifestyle. There could also be a change in your dietary intake. Maybe you have more inflammatory factors if you have a cardiovascular disease, for example. There is a protein imbalance, so you have an increased protein degradation. You have a mitochondrial dysfunction. So the mitochondrial, it's kind of the engine of the muscle fiber. And you also have a change in growth hormones. So this all leads to a loss of muscle mass and a loss of muscle strength. So this, we're all inflicted by this. And we know that, so if I would have the flu and stay in bed for maybe 2 or 3 days, I would lose some muscle mass. Takes a little bit longer to lose this really fast twitch maximal strength muscle fibers. Takes about 6 weeks. And the reason why we know so much about this is research that's been done on people in space, because in space you don't have any gravity. You don't have any mechanical loading on your muscles. So you will lose a lot of muscle mass and bone mass. And the only way to recover muscle strength is by exercise, by mechanically loading your muscles. Going back to the sarcopenia process, it's more challenging to recover your muscle function if you're older than if you're younger. So why do muscles get weak in myositis then? Well, we know that inflammation is there from the beginning, but then if you respond well to the treatment, you will see that probably you don't have so much inflammation left in your muscle and your CK levels are normal. But many of you have not regained the muscle strength that you had before. So we think that the inflammation are immune system mechanism. But then we have seen some metabolic changes that we think are non-immune mechanisms. And we know that corticosteroids do have detrimental effects on your muscle. And then we have inactivities. So there might be several factors all contributing to you having less muscle function. We have seen expression of MHC class 1 on the muscle fibers. And this is a set of genes coding for cell surface protein. And this MHC class 1 is not supposed to be on the muscle fibers. But we think that these changes induce reduced muscle contractility. There are lower numbers of capillaries. And the capillaries that are in the muscle, they're swollen. And they're expressing pro-inflammatory cytokines. And lactate is produced as a product of energy consumption in the muscle. So high lactate levels could be a sign of reduced aerobic capacity in the muscle. So lactic acid is, that burning feeling in the muscle when you have been working out. And one study showed that individuals with established myositis, they've had the disease for more than 1 year, or in many cases several years, they had an abnormally high lactate levels in the blood following an exercise bout compared to healthy controls. The capacity local in the muscle. But another study show that there wasn't a difference between patients and healthy controls. So we need more research to understand the role of this increased levels of lactate in muscle. Other factors could also be a lower level of phosphocreatine in rest and during exercise. Now, I have a slide on that later on, but phosphocreatine is a substance that is really important in the muscle energy consumption during the first 2 minutes of muscle work. Patients also have low proportion of oxygen-dependent endurance muscle fibers. So in the thigh muscle, we have different types of muscle fibers. We have the fast twitch fibers. So, Usain Bolt, when he's running 100 meters, he's only using these explosive, really fast twitch muscle fibers, and they're not dependent on oxygen at all. But then you have a slow twitch muscle. So a marathon runner, or Mo Farah here on the left, he is good at running long distances. So he had good muscle endurance. So his muscle fibers are oxygen dependent, so they can work for a long time. Then you have the satellite cells. It's kind of baby muscle cells that haven't developed yet to be a full-grown muscle cell. So when you exercise, you will trigger these satellite cells to start to grow and become a muscle fiber. So that is what's happening in muscle regeneration. So when you exercise, you can train this, you can decide into what type of fibers the satellite cells will go. So since Mo Farah, he's running long distances all the time, so his baby satellite cells, they would probably grow into slow twitch oxygen dependent. And Usain Bolt, his satellite cells will probably go into the fast twitch, non-oxygen dependent fiber types. And in myositis, you have fewer endurance muscle fibers, the slow oxygen dependent. So from my clinical experience, many patients say that, well, I could be pretty strong, but I have a reduced muscle endurance. So this could be one explanation, so that you have fewer endurance fibers in the muscle. And I think in the thigh muscle, you're supposed to have like 50-50. So this home exercise program is the one that I started to develop long ago. So it pertains of a warm-up. You could just walk or do some biking, but you can also do some step-up exercise as a warm-up. And this is a pulley apparatus so when I push this arm down, the other one will go up automatically. So this is a good exercise if you have very low muscle strength, so you're not able to lift your arms above the head, but you can still train your mobility in the shoulders. We know that patients with polyangioma myositis have about half of the grip strength that would be expected. So I think it's important that you also do hand exercise to work with your hands. So you can work with a petit dough or whatever tool you have, but it's important that you try to strengthen your hand. And quadriceps, the front muscles of the thigh, they're often very weak in myositis. So this is a way to train the quadriceps. To lift your arms above the head. Here I am having a 1 kilo weight, but you can work with a rubber band or other free weight or just against gravity. So here I'm working with the hip extensors and the hip flexors. And the neck flexors are also a muscle group that are very affected in myositis. So perhaps you have difficulties lifting your head up. So in this way, you can work with your neck flexors and with your abdominal muscles. So you should do about 10 repetitions per task. But it depends on how low or how good your muscle endurance is from the beginning. And you can combine this program with a 20-minute walk. And in our studies, we have had people doing this exercise program 5 days a week for 12 weeks at least on a moderate intensity. So this is the program that we evaluated first for patients with an established disease, but then also in patients with a recent onset polydermatomyositis, starting after about 4 weeks after diagnosis and introduction of medical treatment. So what we could see that the program improved muscle strength. So if you have a pronounced weakness, then you improve your strength. But it also improves muscle endurance if that is low. It improved aerobic capacity, and that is pertaining from the 20-minute walks. We saw signs that this kind of program could reduce fatigue and improve quality of life. We don't know if it reduces CK levels or not. We know that after any kind of moderate or high intensity exercise, your CK levels will go up. But then they will go down again after about 24 hours to your normal levels. What we could see was that over time, over a 12-week time, there was no increase in CK levels after this type of exercise. So when we evaluate this program in the randomized controlled trial in patients with recent onset polydermatomyositis, we could see that the exercise group actually had somewhat lower CK levels than the non-exercise control group. And we didn't see any signs of increased inflammation in muscle. So we took muscle biopsies say that we took the biopsy from the left thigh from the beginning, and then we took another biopsy after 12 weeks on the contralateral side. So we didn't want to see any changes from the previous biopsy. We also looked at the thigh muscles in magnetic resonance imaging, and still no signs of increased inflammation. What we could see was an increased proportion of these type 1 fibers, the oxygen-dependent fibers. So this could explain why patients had an improved muscle endurance after this program. So today we use this program as a startup program. We start day 1 after diagnosis. And after, let's see, where am I in my slides? Yeah, so I think it's good to get started together with a physical therapist if possible. Well, it's difficult to say exactly how many repetitions you should start with. So I use this Borg scale. I don't know if you've seen it before, but it's here you can rate your perceived exertion after doing an exercise. So if you say 0, then it's no exertion, it's very easy. Or if you say 10, then it's extremely strong, almost maximal. So when you start doing any type of exercise, if you haven't exercised before, or you have an active disease with high disease activity, much fatigue, and so on, you should start on a 2 or a 3. 2, 3, light to moderate exertion. And then you start there. And then over time, you build up, you do more, and you increase the number of repetitions, you increase the time that you exercise. So when you are used to the exercise and you know that it's working, you can actually exert yourself to between 5 and a 7. But it takes a long time to build up to that. So it's very good to start on a low exertion and then build up slowly, and see how much you can tolerate. So from my clinical experience, it's not dangerous to overdo it at some point. Then you will only learn that, okay, I did too much. And then I go back and see how I can maybe in even smaller steps or do something else instead. Yeah, so you should always try to challenge your muscles, not do the same thing all like year in and year out. You should try to do different things. You need to challenge your muscle. You need to try to do a little bit more from time to time. And I think that starting, it's good to do short exercise sessions, like this program for 50 to 20 minutes. And then you can have your 20-minute walk at another time during the day. So you don't have to do everything at the same time. And it's also important that you change between doing leg exercise and arm exercise, training your core muscles, so that you don't do all the leg exercises at the same time, perhaps overexerting. So, encouraged by the results from our previous home exercise studies, we wanted to test. So what happens if you do a more intensive resistance training? So here we included 8 patients who had the disease for between, I think it was between 2 and 20 years. And here we did more resistance training. We had a warm-up for 10 to 15 minutes, but then it was resistance training in these 5 muscle groups. And we worked on a load that we called 10 voluntary repetition maximum. So that's a weight that you can lift 10 times, but not 11 or 12. And that will end up being about 70% of your maximal strength. But of course, we started on the lower intensity, building up. And one woman, she had hand arthritis. So we had to adapt her weights so she wouldn't have pain in her hand, for example. So there's always a way to adapt your exercise so that you can do it. So they trained 3 days a week for 7 weeks. And we saw a very marked improvement in muscle strength, some improvement in muscle endurance, and improved function in daily life. And this type of exercise was the first that we could show that it could reduce disease activity. So I don't know if you're aware that your physician have you rate how you do overall on a visual analog scale, and they examine your disease activity. You perhaps fill out the health assessment questionnaire, and they look into other organ involvement in your body, and they have improvement criteria. So if you improve more than 20% in 3 of these 6 measures, you're a responder with reduced disease activity. And here 2 patients were responders. And we checked gene expressions in the muscle biopsies and saw that genes that regulate inflammation, they were downregulated. And genes regulating fibrosis were also downregulated after this type of really intensive exercise. And this is what you would expect in healthy people too. And so we saw a lot of improvements in muscle strength from that program. But our clinical experience and the patients told us, well, what about the muscle endurance? We're limited in muscle endurance. So we wanted to check an intensive endurance exercise program. And this was a randomized controlled trial. So we randomized patients who had the disease for at least 1 year into exercise on a bike, 30 minutes on 70% of maximal effort, then doing 20 minutes of muscle endurance. Here we worked on a 30 to 40% of maximal strength. So they did 30 repetitions, but weren't able to do that much more. So 3 days a week for 12 weeks. In the exercise group compared to the control group. We saw reduced lactate levels in muscle, an improved mitochondria function, and also an increased numbers of capillaries in the muscle tissue. The exercise group improved in muscle strength and endurance, and also in ability to perform daily activities, and it had improved quality of life, physical function, general health, and less fatigue compared to the control group. So in this is the mean value from the beginning of lactate levels in the exercise group. And here on this axis is the time that they could bike before they had to stop from exertion. So from the beginning, they could bike about 15 minutes and they had higher lactate levels. And after the exercise, they more than doubled their biking time, and they had lower lactate levels. This is the non-exercising control group, no changes. And what's exciting is that everyone in the exercise group had a reduced disease activity compared to no one in the control group. And we also saw these signs of reduced inflammation. We saw genes regulating muscle growth were upregulated. Genes regulating angiogenesis, can't say the word, but creating more capillaries. I'm sorry. That also was upregulated. And this was changes that we could see were not happening in the control group. So I think this results really show that intensive exercise is an anti-inflammatory treatment. So it will reduce your disease activity and inflammation and will improve the muscle metabolism and probably restore some of the changes that you have from the inflammation and from the corticosteroids. And creatine supplementation. So phosphocreatine, I touched upon that earlier in the session. Phosphocreatine is an important part of the muscle metabolism. So you use it together with the ATP. So during the first 2 minutes, you use a lot of ATP and creatine. So again, Usain Bolt, when he's running 100 meters, he doesn't have the time to take a breath. He doesn't need any oxygen at all. And his muscles are only working with this glycolytic metabolism. And so we've seen that patients with especially dermatomyositis, they have lower levels of this phosphocreatine in the muscle. And that is both in rest, during exercise, and then after exercise. So that could be an explanation why your muscle isn't working as they should. So we did a study together with the King's College in the UK. So patients were randomized either to creatine supplementation and exercise, or a placebo supplementation and exercise. And we could see that the creatine group improved more from the exercise than the control group who only exercised. And we have quite some patients now who are on this creatine supplementation. It's important that you have stable medication if you want to try this. And it's important to talk to your rheumatologist before starting, because you have to have a normal kidney function. Otherwise, there is no known side effects. So you introduce the creatine in addition to 2 to 3 days a week exercise. So it's good to have a regular exercise habit before starting, because if you don't exercise, there is no rationale for taking creatine. So we start with a loading dose of 8 grams per day, and that equals about 5 kilos of meat. So you get creatine, you have creatine in your muscle, and you get creatine by eating fish or meat. And then you continue with a maintenance dose of 3 grams per day for 3 months. So you put the creatine powder in your morning drink, coffee or tea or whatever it is, and then so you take it every day. And then after you take a 4-week break from the creatine and continue to exercise. And then you start again all over. And yeah, creatine supplements can only have positive effects on your muscle function in combination with exercise. So if you don't exercise, don't take creatine supplementations. And now I'm going to leave my slides for a while to talk about the home exercise program in IBM. So bear with me. I'll be back.
While you're doing it, we have a question about when the creatine should be taken relative to exercising. Does it matter if you take it before or after exercising that day?
No, it doesn't matter. So you take it every day. So this is a home exercise program that was developed in Australia and published in 2007. And I started to pick this up in my clinic about 6 or 7 years ago. So this is what I offer everyone with IBM at the Karolinska. It's quite an ordinary home exercise program targeting the important muscles in IBM. But what's special is that you should do it twice a day for 16 weeks. So it's kind of very frequent, short sessions of exercise. And again, I'm working with this Borg scale to decide on how many repetitions you should do. So the first one is standing up from sitting. So in IBM, this is an activity that gets more and more difficult over time. And my philosophy is that it's good to do functional training. You get better in doing something that you do a lot. So if this is something that you have problems with, then this is what you should be doing. So it doesn't matter if you need to help the arm support to get up from the chair, but then try to sit down really slowly, because when you stand up, your muscles are shortening, but when you sit down, they are lengthening. And when they're lengthening, you work eccentrically, and your muscles are about 40% stronger when they lengthen, when you do working eccentrically. So get up from the chair. It doesn't matter if you need help from your arms or not, but then try to sit down as slowly as you can. And here you can, this picture, they have a rubber band. So you should try to have your arm against your thigh and then just work with your wrist flexors. You can work with free weights or against gravity. Then doing toe lifts to lift your heels up and down. So we know that it's the thigh muscles, but also the more distal muscle groups of the legs that are affected. Working with the biceps. Here we have free weights, but you can work against gravity or with rubber bands. And here you are leaning against the wall, trying to lift your toes up and down. And if you're not able to do that, you can sit and just have your feet stretched in front of you and then try to lift your toes. So here, this picture, they have put a little weight cuff on your feet if you need a little more resistance. So this 5A and 5B, they're the same exercise, but just different ways to do it. A rowing with a rubber band. to work with your shoulders and your back muscles. And here you lift your arms up, working with your shoulders, and again working with your quadriceps by extending your knee. And if you're not able to do this, you can try to lay down and lift your leg up instead. So this 8B is easier than this one. So here you can see, I say, so the first 3 weeks, you can do it maybe once a day or twice a day, but repeat until you say, well, this is a moderate exertion on this Borg scale. Then you increase a little bit from time to time, twice a day, but you can say, do repetitions and have loads that gives you a heavy exertion on the Borg scale. So from my experience, almost everyone tolerates this training program. I think that you shouldn't expect a lot of improvement, but many of my patients do see small improvements in walking ability and standing up from a sitting position, for example. I have a few patients that have been able to start with this and then build on to doing 3 hours of exercise every day in a gym, aquatic training, walking, doing different things. And they have been able to improve a lot. But then, so that is a really small group. But there is an even smaller group that have problems with tolerating the exercise. So my advice is to start on a low level and then have regular follow-up with your physical therapist, if possible, after just 1 or 2 weeks, just to see how are you doing with this program. But we can't tell who will respond and who will not. So we just have to try. Yeah. So this program improved muscle strength, ability to stand up from sitting, and walking ability. So this is an interesting picture. So these are all the muscle groups that they tested with a manual myometer. So the shoulder, elbow, flex extension, wrist extensions, hip flexor, abductors, knee extensors, and grip strength. So the line here is the baseline value that they had before they started to exercise. And then you see that they did have an improved grip strength, and they did have some improvement in the knee extensors, the quadriceps. So these are the 2 most affected muscle groups in IBM. And then there, just last year, came out a study from Denmark looking into blood flow restricted training. And the rationale for this is that you take away 70% of the muscle, or the blood flow to the muscle. So the muscle will work in an ischemic environment, and this will trigger the muscle to respond better to exercise. So if you take away 70% of the blood flow, you have the same effect on a submaximal muscle work that you would have on doing a very high intensity training. So this had been tested in 2 case reports, and before they did this randomized controlled trial. So 22 patients with IBM were randomized to the blood flow restricted training twice a week, or to a non-exercising control group. So they had a symptom duration of 8 years, and they had a mean age of 68 years. So I think you shouldn't do this if you have a history of deep vein thrombosis, pulmonary embolism, or another known peripheral ischemic disease, cannot have severe heart or lung disease or uncontrolled hypertension. So they took away 70% of the blood flow, and then they did training on this in this leg press, and they did heel lifts, and then they work with the hamstrings as well. So that's the back of your thigh. The effect of this program was the training group, they improved their quadriceps strength about 6%. That's a very small improvement. But the control group that did no exercise, they lost 10% in muscle strength over 3 months. So this study is really important to show the natural, what is happening naturally in IBM over time, versus if you exercise, because then you can maintain what you have for a longer time. And I don't think that this pertains only to this type of blood flow restricted training. I think that pertains to all kinds of regular exercising, inclusion body myositis. And I also want to say something about, so this was the slide I was looking for. I'm sorry. They had improved strength, and they saw some signs of muscle hypertrophy, but not much. And then something about mechanisms for muscle weakness in juvenile dermatomyositis. So I found a recent review article stating that the B and T cells, the immune cells, migrate to the skeletal muscle, and that activates interferon expression. So there's an inflammatory cytokine, and also this gene expression MHC class 1 that shouldn't be on the muscles. And this induces a muscle cell stress with a lower contractility. And also here they have seen lower capillary density, and the capillaries are thickened. So one study had seen that children with myositis have a lower oxygenation in skeletal muscle compared to healthy, but there was no difference compared to children with arthritis. So from this, it would be stipulated that endurance training would be good in children with myositis too. So there's 2 studies looking into a warm-up. The first study had a 5-minute warm-up, followed up by 20 minutes of resistance training, and then in 3 sets, and then 30 minutes of a treadmill walking on 70% of maximal effort, followed by stretch, twice a week for 12 weeks. And in this study, the children had an improved aerobic capacity, improved muscle strength and muscle endurance. They had an improved grip strength and improved functional tasks and quality of life. The other study looked at only stationary biking on 65% of maximal effort. And also here they saw an improved aerobic capacity and improved walking ability. And again, in all of these studies, there has been no signs of increased inflammation or detrimental effects. So there are recommendations for how much you need to exercise to improve, for example, muscle strength and muscle endurance and aerobic capacity. So as you see in this slide, this pertains to healthy people. So to improve your strength, you need to do resistance training on 8 to 12 voluntary repetition maximum. So that means you're not able to do so much more than 12 repetitions. And you need to do it 2 days a week. Muscle endurance, you also need to train that 2 days a week, but with lower loads and more repetitions. And if you want to improve your aerobic capacity, you need to work out, do any activity that would increase your heart rate to between 60 to 80% of your estimated maximal heart rate for 20 to 30 minutes. And what we've seen in the studies in adult polydermatomyositis, and I think in the children too, they don't diverge so much from these recommendations. But you have to go, but if you haven't exercised before and if you have an active disease, you need to go in on the lower level and slowly build. There are also data on health enhancing physical activity. So these are kind of tough requirements. So to improve your health, and that means reducing the risk of cardiovascular disease, diabetes, and many cancer forms, you have to be physically active 150 minutes on a moderate level per week, or 75 minutes of more intensive physical activity per week. Then you should do resistance training twice a day. And they also recommend balance training for people over 65 years. I think that people with inclusion body myositis needs to exercise even more regularly than 2 to 3 days a week, perhaps every day. I think we've gone over this a little bit. When you have kind of done your initial home exercise, you can go on to do whatever you enjoy to do: aquatic training, gym exercises, walking, Nordic walking, biking, any exercise that you enjoy. And you can calculate your estimated maximal heart rate by taking 220 minus your age. So then you know your estimated maximal heart rate. So if a person is 45 years, you take 220 minus 45, that gives 175. And then you calculate a range between 50 and 70% of that. So this is the range of heart rate that you need to be in to improve your aerobic capacity. And there is a very strong association between aerobic capacity and health. And that is both in healthy people and myositis. So for each unit that you increase your aerobic capacity, you will reduce the risk of having like a cardiovascular disease. It will prolong your life. So you can also reduce high blood pressure with regular physical activity. And just to say a few words of what I'm doing now, we do a training study at the moment, including patients with recent onset active polydermatomyositis, and we do high intensity interval training, starting no later than 6 months after the diagnosis. So they bike for 30 seconds as fast as they can. So this is a maximal effort. And then they rest for 2 minutes, bike on a lower intensity, and then they go on to another set of intensive training. So they do altogether 6 sets of maximal biking. And this type of exercise has been proven to be more effective to improve your aerobic capacity. So we have a feasibility study going on to see if people will tolerate this type of exercise and see what changes it can induce in muscle tissue when it comes to inflammation, disease activity, and muscle metabolism. So I think I need to stop there. I've been talking a lot. Time for questions.
Well, thank you, Dr. Alexanderson, for the presentation. And I've got some chat or some questions here, and I'm going to call on some people. And we want to start with Anne, who had a question for you. Anne, are you there?
Hi, guys. Yeah, good afternoon. Thank you. Thanks. The science is very interesting and very helpful. I do appreciate it, the details in that and sharing all of that. So thank you for that. I come from a world where exercising and activity was my life. I mountain biked probably about 10 miles every weekend. I worked out with a personal trainer twice a week, doing power lifts, deadlifts. So it's not lack of interest or enthusiasm or expertise or will to exercise. It simply comes down to ability, right, and the pain. So you mentioned a couple of words in your presentation, one word being tolerable. What's tolerable? And another word you used, enjoyable. So exercises become intolerable and unenjoyable. So I guess my question to you is, if it hurts, how do you expect folks to still exercise and somehow just work through that pain? Is this just becomes a mind over matter issue to you?
I know that a lot of people with myositis have pain, and it could be most muscle pain and joint pain, perhaps. So I've been interviewing people about myositis, people about pain in myositis. I'm sorry, and they said that if you find a level that is optimal for you, then exercise can reduce the pain. But if you do too much, that will increase the pain. So I'm wondering if you have, since you were so active before, did you go in on a low level and build slowly, or did you go like start bike and do long exercise sessions initially?
I've been mountain biking and I've been working with my personal trainer for 10 years. So,
yeah, I think maybe you do too much if your exercise gives you intolerable pain.
No. You misunderstand.
Okay.
Before I was diagnosed with myositis, it wasn't painful.
No.
Okay. The program, the exercise program that you presented here is all very familiar to me, and but it can't be done when within the first 10 seconds of engaging a muscle, it's extremely painful.
Okay. I see. Well,
is that the first time you've heard that? Are you familiar with the
no,
fact?
what I usually do in that case is that I don't do the whole program at the same time. I divide. So maybe you divide it into 3 different sessions over a day. You see, so you do like maybe 2 exercises in the morning, and then you do 2 other exercises in the afternoon. So you don't do the whole program at the same time. Have you tried to do aquatic training in warm water?
No, only because simply writing or typing a letter is painful. So I can't imagine that actually trying to do a backstroke is not going to be painful. And I'd really hate to drown in the pool.
Okay.
So again, I appreciate the presentation and the science behind all this. I think maybe what might be worthwhile to add to it is you know, it does kind of become a psychological thing at this point, because again, I'm an enthusiast. I loved exercise and I had no fear of it. I loved it to death. But now it's too painful. It's too painful. And so now being able to address it in your presentation, going, look, here's all this awesome stuff you should be doing, can be doing. But if you can't do it and it's intolerable and unenjoyable, I mean, that really becomes the dread. I don't think anybody that's in this meeting, you know, the 30, 40 people that are here are sitting back going, I just don't want to exercise. I hate it. Some might be, but I think some folks are probably just like, it hurts too much to do anything that you just suggested here.
Okay.
And just to follow up quickly on that, I appreciate you bringing that up, Anne, because I personally have the same issue. Pain was my first symptom of my myositis and continues to be the symptom that is the most challenging for me. So yes, exercise for me is very difficult as well. So what I do is I do try to break it up, but when it comes to lifting weights and so I can't do it. So I just do what I'm able to do. As long as I'm able to do something to get my heart rate up, if it's just walking with my cane around the yard a little bit, that's all I'm able to do right now, then for me, that's a success because it's more than I was able to do.
Yeah, totally.
Yeah.
I appreciate that. Thank you. Thanks for letting me speak. Appreciate it.
Absolutely. We appreciate the question. And thank you, Dr. Alexanderson. General question about what to avoid, and also a follow-up question on whether too much exercise could actually damage muscles. What do you think?
So so what to avoid? I would say if you are on high doses of corticosteroids, or if you have been on steroids for a long time, to avoid any damage or injury to your like a spinal fracture or anything like that, vertebral fractures, I would not do free weights, working with the kettlebells, or maybe not like jumping or running, and also try to work with lower weights and do more repetitions for safety. And don't do any back rotations with resistance, also for safety if you're in a risk of if you have osteoporosis or osteopenia. Other than that, I can't say that I kind of in general say that there are things that you should avoid, because you're all very different when it comes to how much pain and fatigue you have, and how muscle weak or muscle strong you are, or how your endurance is, and if you have lung involvement. So it's really comes down to meet each individual and see what they're able to do. But I mean, if you have a severe interstitial lung disease, we don't know how much you can exert yourself if you have this pulmonary arterial hypertension, for example. In our studies, we've had people with interstitial lung disease, and it hasn't been any like unwanted effects. So it all comes down to go in on a low level and increase slowly. And what was the other question? I'm sorry.
No, that's okay. I think
another question.
The rest of it was about potential of damaging your muscles.
Oh.
Yeah.
I don't think so.
Okay.
If you overdo it once, you will probably get a lot of muscle soreness, but you won't harm your muscles. You will only learn that you did too much. And, I think there could be different kinds of pain. I mean, delayed muscle onset soreness. No, delayed onset muscle soreness. That is what everyone gets with exercise. And I know that if you have myositis, you may have higher level of this muscle soreness, and it might stay for a longer time than in healthy. But if you have a little muscle soreness, that only tells you that you have worked with your muscles in a good way, because you need that feeling that you have done something, that you are fatigued in a muscle, in order to the muscle to regenerate and get stronger. But then if you do too much and you have intolerable muscle soreness, and then you've done too much. You need to take a step back and see how you can modify your activities. So it's important to have a balance between activity and rest. You need to rest as well.
Yes, I think that's important to make sure you're doing a balance. You know, you're not just
Definitely.
starting out at, you know, like that maximal. Good. Martha, did you have a question that you wanted to ask, Martha?
I presume you can hear me.
Yes.
Helene, yeah, wonderful. Helene, thank you so much for another excellent presentation. Just an ongoing question I have related to the blood flow restricted exercising in the IBM population, and specifically that 10% reduction in function in a 3-month period, which just sounds awfully quick for IBM, you know, from our own experience. And I'm just curious about that, and you know, how confident are we, since that is the control group in that number?
Well, I do agree with you that 10% seems to be a lot. I think it could be. I mean, this was a small study, and I think it was a bit underpowered. And it could be. I mean, they found an antibody in inclusion body myositis, for example. And this antibody, if you have it, you will probably have a faster progression of muscle weakness. So I don't know if by accident there were more people with a faster progressing IBM in the control group. We have discussed that a little bit. It is a fast progression. I agree, but I can't tell you why.
And again, it was such a small study.
Yeah, it's a small study, but I think it does really show what I see in my clinical practice, that you can maintain what you have for a longer time if you exercise, if you have IBM.
Marnie asks, are there any summer programs you offer where myositis patients can come study and do PT with you? Or do you have one-on-one Skype sessions available? And are you training other PT instructors in the U.S. particularly, such as like in California?
Well, that would be great to have a summer school. I love that. Well, I think there is a way, I mean, to go as an international patient to see me in my practice. So I can give you information, Jerry, on how to contact and how to come for a visit at the Karolinska with me and the myositis team, so that we see patients from all over the world.
All right. Well, thank you so much for your time and for joining us and sharing all this wonderful information. We truly appreciate it.
I enjoyed it.
Great. We love to have the experts join us, and be sure to register on our website, understandingmyositis.org. And if you have some positive experiences to share about exercise and how it's affecting you and improving, or whatever the case is, visit our brand new patient and caregiver experience site, myositislife.org. And if you have any questions, feel free to contact us, and we'll reach out on your behalf and see if we can find answers. So everybody have a wonderful day. You have a wonderful evening.
Thank you.
And we'll see everybody again real soon.
Thank you.
Thank you.